Okay, so we are going to be presenting an interesting case that we recently had on the ward. Uh, the, we've entitled our presentation as when autoimmunity refuses to pick a side, and I think as we go along, we'll probably get to see why. Um, so our patient was, sorry, my slides are not moving.
We're still on the first slide. That's what I see.
Slides are not, I can just try and reshare because I'm clicking next and it's not moving anymore. Sorry. Okay, there we go. So the patient is a female, EC, 11 years old, resides in Makeni, which is an area that we have in Lusaka district. She first presented to us on the 11th of, I must say, this is supposed to be September as opposed to August. She is a Christian by religion, and she came to us as a referrer from one of our first level hospitals, which is Kanyama General Hospital, for further management of suspected autoimmune hepatitis. On admission, her vitals, the temperature was at 35.6, the story rate was 18, heart rate was 101 press per minute, saturation was at 100 at room air. This is when she just arrived to our ER. So the presenting complaints were that she had generalized body weakness, yellowing of eyes, headache, and abdominal pain. This had been there for about a month. The abdominal pain was noted to be generalized, non-specific, including the headache as well. And subsequently, she developed the yellowing of eyes, which was progressively worsening. But then by the time she was presenting to us, it was resolving. Throughout this period, she had generalized body weakness and also was noted to have weight loss. Her past medical history, drug history, family history, and birth history are unremarkable, but of note is that unremarkable, and she had received all her required vaccines for age at this point. With regards to her social history, she stays in John Lang, which is one of our lower income communities that we have. She has a younger sibling, lives with both her mom and dad, who are basically unemployed and just pretty much do odd jobs, casual jobs whenever they're able to. She is a grade 6 pupil, uses tap water for drinking at home. Nutritionally, she seems to have 3 meals a day. Uh, Breakfast mostly consisting of bread and tea, lunch, shimmer, relish, which includes meat, fish, eggs, and vegetables, which is pretty much a basic meal for Zambian family, and supper is just the same. So, of note on examination, she was alert, deeply jaundiced, and was not pale, and was not in any respiratory distress. Her respiratory system exam was unremarkable. CVS at this point was also unremarkable. Her abdominal exam was, she was noted to have moderate tenderness in the right upper quadrant with no distension, had a hepatomegaly of about 2 centimeters below the costal margin, and had no edema. So the results that we're seeing right now are the results from the referral facility, because when at the point she was presenting to us, it was 1 month into her illness. That prior 1 month, she was going to the referral facility. So she presented to them on the 7th of August. And at this point, they did biochemistry tests, which showed a total bilirubin of about 14.9, direct bilirubin noted to be 128, indirect 66. I think so it was meant to be 149 as opposed to 14.9. And ALT was elevated at 383. They also did other investigations, hepatitis screen, which was negative, both A and B. They did a wider test, which was also negative. She returned to them on the 19th of um, August because the jaundice was worsening. So when they repeated the investigations, they did an HB at this point was at 13.6. The BBC was 6.2. Platelets was 447. ALT had gone up from 383 on previous hospital visits to 961.29. The AST was at 694. The direct bilirubin was 385.49, and the total bilirubin was 460. An ultrasound was done at that point from a private facility near the referral facility, and they noted a hepatomegaly of about 5.3 centimeters, and also noted inflammation of the gallbladder wall. So the next day, she went back to the referral facility. They repeated the scan from there, and they noted that the scan was actually normal. Following day, she returned to the hospital. They did liver function test again. The ALT now had gone down from the previous 961 on the 19th, went down to 302 on the 21st. The AST also went down from 694 to 210, and the total bilirubin was at 373 at this point. So of note is that the jaundice, like we noted, was clinically resolving, including the LFTs, which were also normalizing as we were going down. So at admission on that first presentation to our facility, a diagnosis of resolving hepatitis, likely hepatitis A, with the resolving cholecystitis, really not an autoimmune hepatitis, was made. She was then admitted to our ID department, which is what, AO5. At this point, they collected baseline investigations for blood count, LFTs and KFTs. 2 MCS was done, and she was placed on a high carb, low fat acid diet. So the full blood count on our first admission, her WBC was at 314, red blood cell count was at 369, the HP was at 11, MCV was at 33, the RDW was at 24, and the platelet count was at 447. For the liver function tests of note is our bilirubin that went down to now 83, total bilirubin at 143, AST went down to 174, and ALT was going down to 272, and our albumin levels were at 52. The abdominal scan that we did on our end here showed a normal scan. So patient was on the ward for about 3 days, and she was discharged. The jaundice was noted to have resolved at this time and was seen 2 weeks later, came through 2 weeks later with jaundice, which reoccurred. And at this point, it was requested to repeat LFTs and was scheduled for another review. At this point, she was discharged and came back later for a readmission in October. So she came back on the 8th of October. She presented with fevers, headaches, generalized body weakness, and still had yellowing of the eyes, though at this point it was mild, though not 2 weeks prior, it was moderate. She presented with a 3-day history of the above complaints, which were said to be worsening. The fever was ranging between 39 to 40 degrees and was noted to be persistent. On examination at this point, she was ill-looking, she was febrile, her temperature was 38.9 on admission. She had a tinge of jaundice and was noted to have moderate pallor. Respiratory system was unremarkable. For the cardiovascular system, she was noted to have a gallop rhythm. Abdominal exam was noted to be unremarkable and had no edema. A urinalysis was done at this point, noted to have been straw-colored, almost clear. All other parameters were noted to be normal. So an impression of a female 11 years old presenting with sepsis, corifocal, with a background of severe anemia and suspected hepatitis from the previous admission was made with and ruling out hemolytic anemia, ruling out an acquired aplastic anemia, and also ruling out paroxysmal nocturnal hemolysis. So at this point of admission, the plan was to do an LDH, reticulocyte count, complete blood count, PBS, BMA, Coombs test, LFTs, IgG, IgM, C3, C4. She was then admitted and given ceftriaxone, folic acid, albendazole to deworm her. So patient then was then admitted to the ID unit where she stayed for 9 days. While in the ID unit, she had received about 2 units of blood. While she was in admission, while she received 2 units of blood, then when she went to the ID unit, she received 4 units of blood. Then she was sent to the Haematology department on the 19th of October, 2025. So other investigations that were done, a blood culture, urine culture were done and they were negative. TB screen was done, negative. Hepatitis screen was repeated, was also negative. HB electrophoresis was done, was noted to have 100% HbA. Typhoid IgG and IgM were done and were negative. Echo showed a mild tricuspid regurgitation and an ejection fraction of 58. EBVs, CMV, IgG, and IgM were done and were negative. So this is a summary of her complete blood counts that were done during the course of her second admission. Initially, she had, when she first came in October, her WBC count was at 1.96. She had an HP of 1.7. Her MCV was 106. MCH was 34. Platelet count was 23. She had a neutrophil count of 1.9 and lymphocyte count of 0.32. So at this point, she received 3 units of blood. Then it was the next day in the evening, the full blood count was then repeated. The HP was noted to have gone up to 8.6. WBCs are still at 1.45. MCV was normalized. MCH was normal. Platelet counts went down to 19. 2 days later, she was noted to be deteriorating again. So a repeat full blood count was done. And she was noted to have dropped in an HP from 8.6, it went to 4.2. At this point, she received an aliquot of blood. So the next day, HP was rechecked, and the HP went up to 11.4 post 1 aliquot of blood from 4.2. 4 days later, on the 12th, she was noted to have improved, but then 4 days later, she acutely decompensated again. A repeat full blood count was done, noted her HP had dropped to 4.6. She then received 2 aliquots of blood, 2 units of blood, and then 6 days later, she improved, but then 6 days later was noted to be pale again. They repeated the HB, went down to 2.8. An aliquot of blood a unit of blood rather was given. And then 2 days later, the HB went up to 8.4. And then about 5 days later on repeat, 9.7. Of note is that she was also receiving platelets transfusion along the way. It's just not clear how much she was receiving at each point, but she did receive some platelets as well. And also of note is that between the 14th and the 22nd, she was commenced on methylpred and IVIG, which we noted this marked improvement on the 22nd, with the HB going up to 8.4, and 5 days later, 9.7. Her ESR of note was at 180 2 days post-admission. So other labs that were done included LDH, which was 618. A repeat LDH about 20 days later was at 350. Reticulocyte count was at 0.4%. 20 days later, repeat was at 0.5%. C3, C4 were done on the 29th, noted to be elevated. The C3 was at 316 and the C4 was at 50. IgG titers were done and they were within normal, though on the upper end of normal, 1,507. The IgM was also within normal. A direct Coombs test was done and was noted to be negative. PBS was ordered, and the morphology showed the anistocytosis of the red cell morphology. She had also some round macrocytes. She was normochromic rather. She had polychromasia was also noted. With regards to the WBC morphology, she had a left shift toxic granulation of 3+. She had vacuolated monocytes, which were seen, though no blast cells, and had thrombocytopenia, which was noted on the film. A BME was done, noted to have been hypocellular, uh, hypocellular with normoblastic maturation, and was also noted to have full sequential maturation and differentiation with heavy toxic granulation noted. A few large blast cells were noted, about 2% of the, enclosing about 2% of the bone marrow cellularity, and also vacuolated monocytes or increased laden macrophages with iron debris. A few plasma cells seen as well. There were no lipid storage disorder cells which could be seen, and no malignant cells were noted. So the comment from the BMA was that we needed to rule out a chronic infection and anemia of chronic illness, to rule out hemophagocytosis, ruling out a lipid storage disorder, and also recommended to have a BMA flow cytometry done to rule out an acute leukemia, and the repeat BMA to be done, which was not done. So this was our patient, and we'd just like to hear your thoughts on the patient.
Thank you so much for this very interesting and comprehensive history. May I just ask a question? So she did have a transfusion in the local hospital before coming to your center in September. Is that right?
No. So from the local facility, her HB was okay. It was at 13,
Okay.
so they didn't have to transfuse her. She only received the transfusions from our end.
Okay. And a couple of thoughts are, I mean, it sounds like she had been very quickly losing her hemoglobin. Sounds like she
Yeah.
had a hemolytic process. She had a high MCV, massively dropping hemoglobin. And also she had a thrombocytopenia, so potentially could be kind of an immune phenomenon, autoimmune hemolytic anemia versus Evans syndrome, given the platelet involvement. Has she had a DAT at all at any point?
Yes, it was negative. We had a Coombs test, so it was done. It was negative.
Okay, but interestingly, she has a low reticulocyte count, so whatever hemolysis is going on, maybe affecting her erythroid
Mhm.
progenitus. But interesting. Savannah's got her hand up. Savannah?
Yeah, thank you. Thank you, Leila. It's an excellent case and very well presented. Thank you. My question is, how is she now? Is obviously this has been a couple of months. Have you continued with the steroids or just the pulse of that methylpred kind of settle things? Uh, okay.
There-
IVIG, methylpred.
Yes.
Yeah. Marked
So,
improvement initiation of therapy. Okay.
so she's been on oral prednisolone that she's been taking. She came back for a readmission because she had an acute deterioration, but has since been discharged.
Okay. And how much prednisolone is she receiving now?
So initially she was at 2 milligrams per kg, and then was tempered down. But I think as it stands, back on the she's been tempered down rather from the 2 milligrams that she was receiving on alternating days.
Okay. Um, yeah, so I mean, given that she has had a response, and I'm presuming that the rest of her blood count is now normal, her platelets have returned to normal.
She still has the
Can I just help?
thrombocytopenia. Go ahead, go ahead.
Yeah. So I think last time that she came through was 2 weeks ago, and she just came in. We're managing her for an abscess that she developed post BMA, but the HB was, I think, above 8 at the time that we admitted her. And at the
Right.
time that she came, we had started tapering down on the prednisolone, but she hasn't had any drop in HB to the levels that she was dropping before we started the IVIG and the methylpred.
What about the platelets?
Platelet count, I think it had dropped at the time that we admitted for the abscess, the gluteal abscess. It was it was around 20 something. The platelets had dropped.
Okay.
Yes, it didn't show a pancytopenic picture because I think WBC were elevated. That's the platelets that she just had a thrombocytopenia, but HB was at 8. WBCs, I think they were almost at 20, if I can remember well.
Mm-hmm.
That
But
was like two.
yeah. And her liver function test is now back to normal. Has she still got bilirubinemia? Do you know if that's been repeated?
I think I may have to check on that one, but clinically she wasn't she didn't show any signs of any liver dysfunction, and also on examination there wasn't any hepatomegaly, and even the urine was very clear in this in this time that she came 3 weeks ago.
Yeah. I mean, it's curious that the direct Coombs test is negative. It's unusual in autoimmune hemolytic anemia. Sometimes you might see it if the cells are being, removed really, really quickly. And it depends on, you might at some point, if it's not terribly expensive or out of pocket, you might want to repeat that. I mean, we have seen occasionally autoimmune bicytopenias, even pancytopenia. We've had one child. We've tended to, particularly for the hemolysis. I mean, this sounds like it, but hard to know. It is possible that this child has had some sort of the differential essentially is that, they have had a non-A to E hepatitis, which then led to some kind of an aplastic anemia type thing, but then with simply spontaneously, regardless of whether you'd given the immunosuppression or not, the patient has sort of spontaneously recovered. That is right, sometimes described. So where you have a hepatitic picture, then that leads to the same autoimmune phenomenon that gave rise to the hepatitis, then causes a kind of, stem cell toxicity, as it were, like aplastic anemia as a result of acute immune attack on the stem cells. And sometimes, obviously in that situation, you'll get reticulocytopenia, you'll get Coombs test negative, and you'll get, bicytopenia, you might even get pancytopenia. But, it is possible that she then, and that is very well described, made a spontaneous recovery from that. And giving that immunosuppression may or may not may not have made a big difference, because the level of immunosuppression you need for, stem cell directed immune attack, meaning in aplastic anemia, you need a lot more deeper immune suppression with ATG, etc., and prolonged immune suppression with cyclosporin for, to get response. And I wonder if that might be one of, it's tempting to call this autoimmune hemolytic anemia, but the patient does not have Coombs test positivity. The patient does not have reticulocytosis. But so it's, I know that the patient, so it's difficult to know. But I think, the bottom line is the patient is recovering. They've still got, anemia, and they've still got thrombocytopenia. So that it'll be interesting to see the sort of time scale of recovery of that as well. So, I mean, if it would be worth maybe, so I know the poor child has now got some abscess associated with her bone marrow. Obviously having the steroid may not have helped with the healing and so on. But it would be tempting to repeat that to see what her cellularity is and so on. Thank you.
Okay. And just to add on, maybe Dr. Laila can just go to the previous slide. The serial CBCs that we're doing. Yes. So on this summary, so what we're noticing with our patient was when we give her blood. So if you look at on the 8th, when we give her blood, a day or two later, she'll start having fevers. She'll be having temperatures as high as 39. Then would check the HB, it would drop to 4.2. And even on the 14th, it was the same situation. So at this point, we even was thinking about warm autoimmune hemolytic anemia, because should have fevers, then should have these drops. Should have fevers, then should have these drops. So on the 14th, actually, we started a day after this transfusion, we started methylprednisolone. Then on the 20th, when we noted this drop to 2.8, the HB, that's when we decided to start IVIG around this period. Then on the 22nd, can you just go back to the previous screen? Yeah, then on the 22nd, that's when we repeated this full blood count. And that was the first time us having a sustained elevated full HB after transfusions, because each time we transfuse it would drop. But with the IVIG, we felt that she responded to the IVIG. And at this point, we're thinking about a warm autoimmune hemolytic anemia. But then what was throwing us off was the same direct Coombs test. But then we thought, okay, it could be negative in some cases, as it is shown in literature. But then when we did the IgG, IgM, and also when we did the C3, C4, that also completely threw us off. And we're thinking, could it be Evans syndrome and not autoimmune hemolytic anemia? So we're just lost in between the two conditions at that point.
How would you explain the liver disease?
With the liver disease, again, looking at the place where she's coming from, we were thinking, despite coming with a negative hepatitis profile, we're thinking it could still be a hepatitis A, considering the place where she comes from, the hygiene and everything like that. But then when she came through and we did the profile and we didn't get anything, we even started thinking of an autoimmune hepatitis. At that point, we're also entertaining an autoimmune hepatitis. But then again, it was also spontaneously resolving. So
Yeah.
Then that scan that she also had, that she came with from a referral facility, one showed that she had the cholecystitis. So it wasn't really making sense on our end.
But then the repeat was normal next day.
Yes, the repeat was normal.
Yeah.
Did you say that her liver function has completely normalized as well?
So the admission, the 3 weeks ago admission, I didn't attend to the patient, so I'm not sure, but clinically, she didn't have any hepatomegaly and there wasn't any signs of jaundice. I just didn't get a chance to have a look at the LFTs. And at the time that we're preparing this presentation, unfortunately, our system for checking results for patients is down. So we're not able to get the latest LFTs.
Mm-hmm.
So would have loved to present it.
Can you please take the slide back to where you had the bone marrow report?
Okay.
So, I mean, I know this is a dilute, very hemodilute sample, so it's very hard to comment. But if you look at the erythropoiesis, it says it's sort of hypocellular erythropoiesis. Again, I think it's probably very, very difficult to comment on this marrow. But, if you have autoimmune hemolytic anemia, you would not expect a hypocellular marrow or a hypocellular feature. You'd
Yes.
expect it to be kind of, erythroid hyperplasia, hyper ER plasia. So again, it's difficult to. So you've got a negative DAT, you've got reticulocytopenia, you've got a relatively hypocellular marrow, you've got a preceding hepatitis, and you've got bicytopenia. But admittedly, she's clearly responded really well to this infectious insult because she's got now high white cell count. So it's harder to pin it down to autoimmune hemolytic anemia with all of these points. But as you say, all the caveats, there could be this is hepatitis A, but your results were erroneous. It could be that the hepatitis A triggered an autoimmune kind of hemolytic anemia or some sort of Evans syndrome. Again, to see Evans syndrome in the absence of DAT positivity, I don't know, I've not seen it, but it's, doesn't mean that it can't happen, I guess. Yeah.
There was a comment in the chat from Dan asking about lymphadenopathy, splenomegaly, and it's quite relevant, yeah. So thank you, Dan, for asking. It looks like she didn't have any. Were there anything else in the history in the way of B symptoms? And we know she had the fevers. Did she have any excessive weight loss, night sweats, anything else?
She did have some weight loss, but not really excessive weight loss, and it was mostly due to it was a nutritional thing because the mom used to complain that she would not eat or she would complain of abdominal pains, but she didn't have any other B symptoms like night sweats or anything like that. She didn't have that. But it was one of our differentials because initially we thought it could be missing a disseminated TB, particularly abdominal TB, but we did investigate for that. We didn't get anything. And yeah, on the B symptoms, I think the only thing that came close to that was just the weight loss, but it wasn't very significant. I think she just lost maybe about 4 or 5 kgs, if I can remember from the file. But there wasn't any night sweats.
And no dysmorphic features on clinical examination?
No. Developmental history and also in my examination, she was just an appropriate looking child, previously well, and had just this 1 month history of illness. So
well, very interesting. I think this case highlights how sometimes there would be ambiguity and we wouldn't know for sure what's going on with the patient. It sounds and the features point towards hemolysis, but again, that is negative. As Subarna said, it's not impossible to have that negative hemolytic anemia, but it might not be the only explanation in this case because, she's had a high LDH, but that can easily be explained by her liver injury, liver insult to her hepatocytes. Again, the bone marrow is not conclusive with the clinical picture, but she did have an excellent response to steroids. So it would be interesting to know how she is once her steroids are weaned off, or she has another relapse of this, or was it just an initial insult that is completely recovered, maybe spontaneously, or maybe secondary to the steroid therapy. It would be interesting to know. Can I just ask, is she on folic acid, just for completion and remembering the simple things?
Yes, she was actually excellent.
Perfect, thank you. So what are you guys doing for follow-up? Is she coming every few weeks, or how are you looking after her?
So I think with guidance from Dr. Taylor, maybe she's supposed to come back, I think first week of January for a review. So possibly we can then run some of the investigations that you've been asking, so that maybe we can present this case again and we see where we are. I don't know, but she's supposed to be in for a review in first week of January. That's in the next 2 weeks.
Great. And has she ever had the immunophenotyping, the flow cytometry?
No, I think we tried to pursue that at the time that we got the negative Coombs test, but then the labs that are able to do the flow cytometry, the prices that they gave was a bit too much for the parents. They were not able to afford the prices.
Okay, yeah, that's understandable. And also, just as a completion for investigating an anemia, did she have ferritin level? I presume the ferritin would be high anyway in this situation.
Yeah. So the ferritin was
B12
quite.
level. Sorry.
Yeah. So ferritin was very high, and at the time that we got that one, she had received, I think, 4 or 5 units of blood. So we attributed it to the transfusions. But folate and B12 levels, we investigated for that as well. I think we just forgot to include it in the presentation. They were within normal ranges, B12 and folate.
Okay, perfect. Very interesting. Has anyone else got any comments or questions? Do you come across questionable immune cytopenias? Do you have quite a few of those? Does it come frequently?
I think we've been having quite a number, and most of them are secondary to hepatitis. Not quite a number, but I think we've had 3 or 4 this year. The time that I was in the hematology unit, I think we had 3 or 4. And these had histories of having had hepatitis. I think one had CMV, then the others hepatitis.
Perfect. I think maybe when she comes back, if you have access to hepatologist or maybe your gastroenterology team for the immune profile for autoimmune hepatitis, maybe that would be something to do if she's going to be bled again, just for completion, especially if her liver function starts to deteriorate or her cytopenias return.
Okay.
Yeah, very interesting. Perfect. So if there are no further comments or questions, I would like to thank you all for attending today. Maybe we can give you 15 minutes back for your day.
Just a minute, Sama.
Yes.
Joseph and Lila, did you have anything beyond the last slide?
Initially, we did, but
Okay.
no, it's
Are you sure? Maybe you can do it quickly.
Go for it. We still have 15 minutes. A bit more, actually.
we had a change in heart at the end, so it's okay.
Okay,
So
that's
maybe
fine.
the next time when we come and give an update on the patient, we will include what we wanted to talk about, and then we'll
Okay.
hopefully have her tryphin results by then, so we can include them.
Okay, that's fine. Okay, back to you, Sama.
No, that's perfect. No worries. So next time we'll get an update and maybe a little bit of presentation about hemolytic anemia or immune conditions anyway.